Hi, everyone. Coming to you to speak about a brand new test being introduced, that's been introduced by IGeneX, and one that kind of has a special meaning to me. As I'll show you, I'm going to go through the history of culturing. It was culturing that got me started with Lyme, and more than that, it got me started with the view of Lyme as something different than what the dogma has said. I had patients who were culture positive but seronegative. I had patients who had things that were not supposed to be Lyme disease but were. I had people who went through treatment that was supposed to cure it and they were still culture positive afterwards. So let me just get started with how this whole thing began for me. So I get this go. All right. With a bit of a historical perspective. Alan MacDonald, the great Alan MacDonald, was the first one to develop a viable culture for clinical use. This is in the mid-1980s. This is a time on Eastern Long Island where my practice was, where Willie Bergdorfer was there, coming and going. He collected ticks from Shelter Island, which was a bike ride from my home. They're developing IFA serologies because they didn't know what else to do, and that's all they had. But Alan actually came up with a viable culture for Borrelia. It wasn't available to a lot of people, and it wasn't available in large numbers. But nevertheless, by using the culture, was able to demonstrate infection in patients who had symptoms that were not suspected of being Lyme symptoms. And this is how the expansion of the presentation of Lyme became known. It demonstrated infection in patients who were seronegative. I mean, at the time, today, people think seronegativity doesn't exist, but in those days, they thought, how could you possibly have an infection and not show in a serology? But it demonstrated that. It demonstrated ongoing infection in patients who had treatment before. Those are oral antibiotics and even IV antibiotics. If the patients got treatment and didn't completely recover or felt better, but then got worse again, and I was able to culture them, every single one of them was culture positive. It also demonstrates something that's important for you to realize in ordering the IGeneX culture is that the highest yield was obtained if the blood was drawn from our patients during the peak of their symptoms. Now, Lyme disease, I had found that most people with active Lyme have a time of day like early in the afternoon when they feel the worst. I feel like just all the gas just came out. They just have to sit down and have to lie down. Interestingly, that was the time of day around 2 or 3 in the afternoon when they would have a low-grade fever, 99 or so. And that was the time of day when the culture was most sensitive or most able to be picked up. But anyway, these backgrounds, these impressions I learned through the use of culturing really formed the basis of my treatment guidelines that were distributed around the world for free and actually became pretty much the Lyme literature that I led supports. So much of this that we know now as Lyme disease, Tick-Borne disease, came about because of the culturing. Good old Alan MacDonald. Next slide is not running. Go. There we go. All right. So what MacDonald did was demonstrate a lot of things about Lyme that was not appreciated. Birth defects in children born of infected mothers. Congenital Lyme was associated with stillbirth. Crib death. He found or demonstrated Lyme in Alzheimer's dementia. And I had a patient, when I started out, I wasn't a Lyme doctor. I was a regular doctor. I was an internal medicine primary care physician with a solo practice in a small town. And I got to know the people. I was raised there and I knew a lot of people. And one of my patients, lady who at the time was about 70, maybe 72, started to develop dementia. And it progressed pretty rapidly. And to the point where she was really unable to speak. She was unable to walk. She had to be fed and completely taken care of. And she went through all the big neurological evaluations at the State University of New York at Stony Brook at the state hospital. And they said she had Alzheimer's dementia, and that's it. Well, Alan called me, Alan MacDonald, said, hey, I grew Borrelia out of her blood. So with everybody's consent, and this is the days when Rocephin just came out, I put her in the hospital. Again, in those days, you could put people in hospitals. And I gave her IV Rocephin. So I don't know how long she was in on the treatment. Maybe it was about after the end of the first week into the second week. I was walking down the hall in the hospital, and there she was walking down the hall. This is someone who was bedridden and mute. And I said, what are you doing? And she said, I'm going there to the refrigerator to get my yogurt. So not only was she ambulatory, she was verbal and with it enough to realize she needed to have yogurt, and there was a refrigerator there where her yogurt was. It was like, wow, mind blowing. Anyway, so with treatment, she got completely well, back to normal. She was able to drive, go shopping, took care of the checkbook, back to pretty much normal. So it was like a major eye opener. And again, thanks to Alan's culture. Other chronic neurological diseases akin to how many patients of mine had so-called atypical lupus or atypical rheumatoid, and of course the cultures were found to be positive in those. Now, years later, I introduced Eva Saylor and Alan McDonald together, and he helped her with her culture processes. And thanks to Eva, so many new experiments are being done, again, based on culturing. She found, for example, that Borrelia do produce biofilms. She had to demonstrate these biofilms not just in lab cultures, but in actual patient tissue samples. Demonstrated the presence of Borrelia in a variety of diseases. She adopted the vital assays, the ones like cyber-green and so forth, that could actually document growth and growing Borrelia and growth activity. With these techniques and tools, she was able to do antimicrobial sensitivity testing, and of course, demonstrated the presence of Borrelia in patients with post-treatment chronic Lyme symptoms. So these are great, world-changing, great things. What about co-infections? The cultures that Alan McDonald did and that Eva does, they are Borrelia. But, as many as 1/3 of people diagnosed with Lyme, as we know now, don't have Lyme. They've got relapsing fever Borrelia. So it's a totally different family of organisms. If you look through the literature, you find that Babesia, at least in America, is the most commonly found co-infection in patients with Lyme, especially chronic Lyme. Anaplasma, Ehrlichia, rickettsias, if you look into what people do when they analyze ticks, this family of organisms are the most prevalent pathogens found in ticks. And that could be the hard ticks, the soft ticks, the dog ticks, the small ticks. Basically, these organisms are there. We didn't have a culture for that. Bartonella, everybody knows Bartonella. Seems like every chronic Lyme patient has Bartonella to some degree. And now recent reports show that ticks, yes, can carry and yes, transmit Bartonella to people. Also, biting flies, fleas, even mosquitoes have variously been implicated in spreading infections, known to also be harbored by ticks. And so many people, biting flies, anybody who's around horse barns and farms, they know that these can be a big nuisance. And studies have shown they contain a lot of different organisms, again, mostly in the Anaplasma Ehrlichia rickettsiae family. So culturing had never been done before for these very important co-infecting organisms or even primary infecting organisms in our patients. So the importance of culturing, number one, it's a direct test, okay? But secondly, it's a vital test. In other words, a positive result means that the infection you're testing for was present and active the day that blood was drawn, okay? So just as it revolutionized my view of Lyme, a really good culture that's clinically available can really change and improve patient care. For example, and I'm going to show you a lot of examples of these tonight, it can be used to document tick-borne infections as an unexpected cause of many chronic disease states. I can't tell you how many patients have now been cultured showing organisms that were not expected to be there, and they had diagnoses of chronic fatigue syndrome, for example. They can document infection in patients for whom other testing methods were non-reactive. Again, just spoke to a colleague of mine who said, gee, I had a patient, came to me diagnosed with years of chronic fatigue. Every type of test we did on her, tick-borne disease and other things really were not helpful, but we did the culture and she had rickettsia, unexpected. Cultures will document ongoing infection in chronically ill patients, even acutely ill patients, uncover co-infections that were not previously suspected. Again, for organisms there, like the ricketsias, where we only have IFA serologies, now we have a culture. We can find things that we didn't know. We can document treatment failures and reinfections because now we have, again, just like in my days back in the 1980s, we can culture someone post-treatment if they're still sick, and sure enough, you can find infectious organisms in them. And finally, as more experience is gained through culturing more patients and looking at their outcomes, we're going to learn a lot more about treatment, just as I did years ago that, hey, 10 days of penicillin V is not going to cure Lyme disease. Culture positive afterwards. So culturing, of course, is a gold standard for any kind of infectious disease, but for tick-borne disease especially, it's always been very, very difficult. There are technical limitations. Tick-borne diseases basically adapted to thrive in living organisms, even intracellular organisms, and not in artificial culture media. And that's been a big problem until now. Now, even in active infection, immune factors and other factors in host blood can inhibit the growth of the pathogens when they're put in vitro. I remember back in the day with Alan McDonald, he had trouble getting the cultures to grow, and he had bovine serum. And he found that because the bovine serum was commercial, most of the cattle that the serum came from had been treated with antibiotics, and they switched to rabbit serum, which didn't have antibiotics in it, and then it seemed to work better. At least that was one of the things that he went through. Also, what Dr. Sappi found, Eva Saylor, is that organisms, when you take them from a patient in a blood sample and put them in culture, they're in a persister state. They're hibernating. They're not going to really grow. And one of the things that she had to do with her culturing in the clinical samples was that she had to grow them a long time and go to great lengths to modify the culture medium to finally get the persistence into planktonic form. Because at that time, the only way she had to prove that what was growing was Borrelia was by using immunofluorescent stains, which don't work really on the persisters and on blebs and so forth. They have to work on the planktonic sparky form. So that was a big problem. Now, even the planktonic tick-borne disease, especially Borrelia babesia, they grow very slowly. Another problem, if you're going to put something in culture, let it grow a long time to get planktonic, other bacteria, which is in the blood, and we know blood is not sterile, they can overgrow and ruin the culture. So that's only part of it. The other part of it is, all right, let's say take blood from a sick patient, put it in the culture to put it in the incubator, and over time, as something's happening, finally start to see something growing. How do you prove what's in there? Can you use immunofluorescence? Yeah, but it's not very accurate. You can't have an immunofluorescent antibody for every single species and strain of every single organism. It just doesn't happen. So how do I confirm the identity? Well, basically what IGeneX has done, and which makes sense, is use PCR. PCR is readily available. It's a technology that is now mature. And because of that, they call their test the cePCR, Culture Enhanced PCR. Don't be mistaken. It's not just like a routine PCR. It's actually a culture, which is then confirmed by a PCR. Hit the market earlier this year. And already there have been hundreds and hundreds and hundreds of samples, clinical samples, as well as many test samples when this was perfected. It took them over 2 years to do it. And basically, the challenge is to duplicate the in vitro what the conditions are found in living organisms. And that's obviously a major challenge, and they've done it. So they do confirm the positive cultures with the PCR. It's very unique, very highly sensitive. And they went to great lengths to prove that, and I'll show you about that. And the thing, remember, I said about co-infections. This culture from IGeneX is available for Lyme Borrelia, relapsing fever Borrelia, Bartonella, Babesia, yes, Rickettsia, Ehrlichia, and Anaplasma as well. Just to know, each test has to be ordered separately because each organism, very fastidious, they need to have their own separate growth medium, own different PCR primers and all that. So you do have to remember, if you want, for example, a Lyme and Anaplasma culture, you have to order 2 separate cultures. But the lab does offer, I think, I'll show you later, test panels that do combinations of different organisms. So like I said, the PCR is a way you confirm the culture, but a PCR is something that can be criticized. PCRs often don't work in peripheral blood because of peripheral inhibitors and so forth that are in the blood. So the lab had to either remove or neutralize them. The PCR process itself had to be very rigidly controlled and standardized. But what they did, and this is unique, every single positive PCR was sent out to an outside lab for sequencing to confirm the identity and to validate the PCR. And to go further, they actually created reverse Western blots. Now, a Western blot looks for antibodies. A reverse Western blot looks for antigens. So what this does, it proves that something really was present and growing in the culture, in addition to the PCR, in addition to the sequencing. So what were the results? When they sent these specimens out to the outside lab, the PCRs matched the sequence in 100%. In other words, it's 100% specificity. So if you got a culture that shows, for example, Borrelia burgdorferi, it's definitely Borrelia burgdorferi and not something else. It's 100% specific. Now, how about sensitivity? Well, that's crazy because the gold standard is a culture. So how do you test a gold standard without any other gold standard? So there's really no way to tell you exactly, but I'm going to show you some data. In the literature, if you look for culture enhancing of PCRs, at least experimentally, the sensitivity is 6 to 10 times better than a standard PCR. Here's some data from IGeneX. What they did with spiking samples of spiking blood here with Borrelia and then Bartonella, what they do is they serially diluted the spike samples. I'll put my pointer at. See, they diluted 10 to the -4, -5, -6, all the way down to -11. And this first column shows the PCR results. They had to dilute it down to the -11 before they finally got a negative PCR on day 0. But by culturing, that day 0 now became positive because what was not picked up by a standard PCR now is being picked up because the culturing amplified the germs that were there, not picked up by the standard PCR. These values here relate to how much work went into running the PCR, how many, I guess you would say, cycles before you can finally get a negative. What you see here is that with the day 0 samples, that really a lot of amplification had to be done to finally eke out a positive. With the culture, they didn't have to do that at all. I mean, the numbers stayed pretty flat all the way through. And so if you look at the 10 to the -11 negative but positive, you know, it's at least a factor of 10. If you translate this into numbers, limit of detection is less than 10 organisms per ml. Now, again, this just shows with the CQ value of 21 versus here 33. If you ran this PCR as far as to a 33, you'd probably get a limit of detection of much better than that and a magnification factor of much more than 10 times. But this is just the raw data to show you that this is really very, very incredible. Just some examples of things they found in their studies. They found, in terms of Lyme, Burgdorferi, Greenii, Mayonii, Miyamoto, and Hermesii for relapsing fever. They found different Babesia species. By the way, the PCR that they use is a genus level PCR. So they have the ability to pick up all the different species. In some cases, I'll show you, they will give you a speciation, but generally it's a genus level test. Look at Bartonella, Trabecorum. I'd never heard of that before, so I looked it up. And it's been reported in Peru and also in Northern Africa. And here they found it as a sample in one of the patients. Anaplasma, Cytophyllum, and Anaplasma platus. I'll tell you about that in a second. They redid some of the more studies. I just want to show you here. They found Borrelia valenciana, again, more Cytophyllum. And what about these other weird things? Again, when they validated the culture, they took samples from patients and they sent them out for sequencing. And one of them came out Anaplasma platus. What is that? We looked it up. It's a canine pathogen. It causes thrombocytopenia in dogs. In the world literature, there's only 4 reported cases of human infection. They also found, and this is a crazy thing, patient years of diagnosis of chronic fatigue syndrome, a thing called Colpodola. What is Colpodola? Believe it or not, it's a free living organism living in ponds and in soil. It's like pond scum. It's really distantly related to Apicomplexans, the malaria babesia family, very distantly related. But this was identified in chronic fatigue patient. Of course, nobody believed it. So a second sample was sequenced, and again, that's what showed up. In the world literature, I only found 2 cases of human infection. One of them actually went through treatment with atovaquone, and the patient did well. So at least this may be some kind of an off-the-wall thing, but at least we have evidence that it is treatable. But again, if culturing wasn't done, you would never know these things were present. No Babesia tests I'm aware of would ever show Colpodola. And do we have, dog serologies for Anaplasma for humans? Come on. The other question is, could these be contaminants? Well, no. No laboratory that I'm aware of keeps Colpodola pond organisms in the laboratory. So no, these are not contaminants. Same thing with Anaplasma. All right, let's get serious. So again, higher sensitivity than a standard PCR, probably a factor of 10 or more at least, proven to be 100% specific. And again, unlike a standard PCR, if you get a positive culture, PCR confirmed, the day that blood was drawn, the patient has an active infection or had an active infection. Now, why do I bring that up? The naysayers about Lyme say, well, a positive PCR in someone's blood, that just means it could be dead, organisms, because you can see PCRs in mummies, for example. Well, I don't really believe that, because PCRs, or DNA in the blood, gets broken down by DNA aces, so it doesn't stick around long. DNA in tissues, so for example, joints and bone, that could stick around. But it's irrelevant here because this is a culture. If you have a positive culture, something was living the day that blood was drawn. So let me go through some results showing kind of how things are playing out when multiple tests are done on the same patient. Here we have 9 different patients who had a number of different tests done on the same sample and the same day. I made a summary to make it easier to read. And some of the results make sense. For example, there are positive cultures with negative antibodies. Well, that could be because it's very early disease. It could be because someone's immune deficient, especially some very late line where the B cell response gets poor. Also, very high pathogen load. Studies done years ago showed that if there's a lot of antigen excess, a very high pathogen load, the antibodies can get complex to it in what's called immune complexes, and they're no longer freely circulating, can't be picked up by a serology. So, all right, a positive culture negative antibody, you can kind of understand there's some reasons why that might happen. Another one, down here we have a positive culture, positive IgM, but negative IgG. Well, again, it could be an early infection. Also, a very late, highly active infection. We all know, and studies have published on this, that in Lyme, often there is an inability to change epitopes. In other words, IgM doesn't get to change to IgG. What's interesting about this, a couple of things. First of all, this IgM was an immunoblot, and the IgM immunoblots have a specificity of nearly 100%, based on different studies that have been validated with, specified samples. So this is something that's real. In other words, a positive late IgM, if it's an immunoblot, is a real IgM. It's not, a false positive. So in some people, they don't convert from IgM to IgG. And I remember reading an article years ago, but I can't find it. I thought I had a copy of it, where they had a patient with Lyme who had this situation, and they gave the person a flu vaccine. And don't you know, the flu vaccine, the same thing happened. The IgM stayed positive, and the IgG never developed against the flu. So, all right, positive IgM, negative G with a positive culture. You can understand that in one of these two scenarios. How about a positive culture, negative IgM, positive IgG? Well, less active infection, later in the course of treatment, it's not acute Lyme anymore. All of this makes sense, it fits. How about tick-borne relapsing fever? Here's one person, positive culture, negative serology. Again, it could be early disease, immune deficiency, high pathogen load with immune complexes like I described before. So in other words, you can understand situations where this kind of a thing would occur, and it's not upsetting because you can understand it. It happens. How about Babesia? Again, another one with a positive culture for Babesia, a positive IgM, a negative IgG. So again, it could be an early infection where IgG hasn't developed yet, or it could be like I told you about the study with the flu vaccine. It could be a Lyme co-infection. So Lyme has prevented the epitope change from M to G, and same thing happened for the co-infection of the Babesia. So it's kind of stretching it, but yeah, it's something in literature. It's something that we've seen, and you can kind of understand it. Another one, anaplasma. Positive culture, negative IgM, positive IgG. Well, again, a later infection, reasonably intact immunity. All of this makes sense. Here's one. We've got positive culture, negative IFA for rickettsia. Again, could be early disease, immune deficiency, or just the fact that IFAs are really not very sensitive for the rickettsias. And that's been one of the problems in these diseases being hidden to us. But then I'm going to show you things that are real head scratches and caused me to really rethink the whole idea of testing. So that, again, these are samples drawn from patients where multiple tests were done on the same sample drawn on the same day, okay? Here's the actual result. Patient number 1 had a positive Lyme culture, negative Lyme immunoblot, a negative Babesia culture, but a positive Babesia immunoblot. So let's look at the summary I made up. Okay, a positive Lyme culture with negative immunoblot, but the Babesia culture is negative, but the Babesia immunoblot was positive for IgM, negative for IgG. Now, wow, this doesn't make sense. Could it be early disease, really early disease, where you have a positive culture and a negative Lyme immunoblot? Well, I guess that's possible, but if you remember how the results showed on Lyme immunoblots, even early Lyme disease by CDC's own samples, what they consider early Lyme, 93% of the time you get a positive Lyme immunoblot. So 93% of the time you'd expect a positive Lyme immunoblot. So our patient may be immune deficient. The Babesia culture is negative, but the IgM was positive. Well, if this person had an immune deficiency, you wouldn't expect any serology to be positive. If it's early disease, you would definitely expect a Babesia culture to be positive because that's when the pathogen load is the highest. Is it possible that the infections occurred at different times? Maybe the person's bitten more than once. Maybe the person was treated for one and not for the other. So again, it's an example of why it's important to do more than one type of test, especially combining, I'll go through this again and again, a direct test like a culture with an indirect test like an antibody test, especially an immunoblot. Patient 2. Here's a positive Lyme culture, negative Lyme immunoblot. And look at the immunoblot. Go down here, let's see the arrow. Positive on 34 and indeterminate on 23. This is an IgM, okay? Same patient. Here we go. IgM immunoblot was read as negative. It really was negative. The lab can't call that positive because it just doesn't go. So while it's technically negative, what could it be? Well, it could be very early disease where the IgM really is just starting to form. That's possible. Also, you know, a 23 on an IgM, even on an immunoblot, it's a sole positive. It could be virus, autoimmunity, anything like that, because just, again, one band doesn't mean that much. But again, the bottom line here is whenever you see an equivocal test, it's good to go further, get another test done. Again, like if it's an immunoblot, do a culture. If it's a culture immunoblot, get a fish, whatever makes sense, because you don't want to miss a case. Okay, here's another one. Positive Lyme culture, negative immunoblot. Same patient, negative Babesia culture, but a positive Babesia immunoblot. Go through the summary here. Okay, positive Lyme for culture, but negative by immunoblot. Positive Babesia, negative Babesia culture, but positive IgM immunoblot. Again, why is this discordant? Why is immune not showing Lyme, but it is picking up Babesia? Is it really early disease? Is a different amount of pathogens in this patient? Was the patient partially treated? Maybe given something like penicillin drug or cephalosporin for Lyme and didn't touch Babesia? Maybe the person got more than one tick bite and got Babesia at a different time than it got the Lyme. Again, a direct and indirect test together give you a lot more information. I'm showing you all of this in great detail because going back to the first few series where it made sense, well, it's early disease and this didn't happen, these things don't make sense. Patient 4, anaplasma, positive culture, a borderline and indeterminate IFA, 1 to 80. Now, if you had a patient that's the only thing you found in 1 to 80 IFA and anaplasma, you'd say, well, I don't know. I don't think I believe that much. I don't know. Same patient, negative Bartonella, but positive Bartonella immunoblot. Right, now let's look at this. So was this patient partially treated? Again, the results are discordant. Why would there be a negative IgM anaplasma with the positive culture? The equivocal IFA, that could be anything. So I don't even know if that's valid. But again, a positive culture, negative antibodies. Here's a negative culture, but positive antibodies. Doesn't make sense. Was it partial treatment? Was it different timing of different infections? Now, when you're dealing with organisms like anaplasma, which is very hard to pick up with standard IFAs, you're really obligated to do anything else. And the only anything right now happens to be the culture, which, as I showed you, is really pretty good. Number 5, rickettsia positive culture, negative rickettsia IFA. Same patient, negative Tick-Borne relapsing fever and Babesia cultures, but positive relapsing fever and Babesia immunoblots. And that's another head scratcher. Here, the relapsing fever immunoblot is IgG. The Babesia immunoblot is IgM. All right, look at this summary. Why is one positive only for IgM and not IgG? Why is the only other one positive for IgG only and not IgM? Again, are all these patients bitten several times, have different infections at different times? Is there something happening different to their immune system that's never been described before? I mean, I don't have answers to this, but this is showing you new stuff that we've never seen before. And again, I want to emphasize, look for rickettsias. I had a patient sick for a long time, gave all the typical Lyme treatments. That's what her diagnosis was, and so forth and so on. One day I got a call from my local hospital lab of all places where I had a simple CBC done. And they said, you know, we were scanning the blood, doing a differential, and we found an intracellular organism in the white cells. It looks like a rickettsia. And this was a person who had been on treatment, including months of doxycycline in good generous doses. So think about ricketsias. They're probably a lot more than what you thought about or considered, and they're probably even resisting treatment much more so than we realize. So this culture has kind of revolutionized this whole thing. 6, positive Lyme immunoblot, IgM, negative Babesia and Bartonella culture, but positive immunoblots. Now here, we'll go through this. Also, this is an IgM. So again, we have discordant results. I'm not going to go through all this again because the mind is already boggled. But the idea is that the culture is 100% specific. Validation studies on the fish, this for Bartonella shows it to be 100% specific. Immunoblots studies have shown specificities are anywhere from 97 to 100% based on what series is done. So they're very highly specific. So if you get results, some positive, some negative, don't disregard the positive on any of the tests, because when it comes to these that are very high specific, you can believe them, and you should. Now, this one just showing you, patient had positive culture for Babesia duncani, confirmed by the PCR, and this is an East Coast patient. So for all those out there say, oh, there's no duncani on the East Coast, I mean, I've seen it, a lot of you have seen it, but here we have proof. All right, some key findings. Obviously, the combination of a culture and an immunoblot results in a higher yield than either one alone. That kind of makes sense. Testing for only Lyme will miss many other positives, sure, co-infections. The basic idea, of course, is the highest yield is from a combination of tests. One or more good direct tests, like a culture fish test, for example, and the best indirect tests, for example, the immunoblot, the things that you think are likely. And again, just to reinforce what I said on the last slide, the culture, the immunoblots, and the fish are all very highly specific. So if you get discordant results, press the positive one if it clinically fits. Okay, so the other day I was putting these slides together, and I thought, holy mackerel! I actually use an expletive, but I'm not going to say that on a recording. It's like, whoa! When I was preparing, it dawned upon me that what I've been showing you are results that are completely unexpected, especially finding rickettsias in chronic patients who've been treated with doxy. Well, what are the implications? Does that mean that we obligated at this point, finding all these weird things, that we obligated to use combination testing on all patients, including the culture, finding things like colpodellas and dog infections? Does this mean we also need to test for all the major tick-borne diseases, even if they weren't suspected? How many people do you think have, a colpodella? I mean, and more importantly, my background, do we risk liability if we don't do these multiple tests? I mean, it's nice to say, well, we have better outcome if we do a culture, when we do a PCR. But it's more than just being accurate for our patients. We might risk liability if we know the tests are out there and we don't do them. Now, I'm just saying that, not as kind of a push for the lab as a commercial thing. This is something that dawned on me because, I've been through liability concerns myself. Thank God I won all of them. But there are people out there who doubt what you do. Or people who are sick and you say, I don't know what it is. Well, now maybe we have a tool to find it. So this is my thought that actually is chasing my wife around saying, look at that. What do you think? Because it really was like a light bulb moment for me. Anyway, let me just finish up by saying what the lab has available, what IGeneX has available. The culture test, you can get them one at a time for each disease, one at a time if you want, or they can offer you culture panels. These are the 3 panels they offer. One is a borreliosis panel. It's the Lyme and relapsing fever organisms in that one panel. The second one is what they call a co-infection panel, which is everything but Lyme, the Babesia, the Bartonella, the Ehrlichia, Anaplasma, and the Rickettsia. Then their tick-borne disease panel is kind of a complete, it's all of them. It's the Lyme, relapsing fever, Babesia, Bartonella, Ehrlichia, Anaplasma, Rickettsia. Sounds like a song. We need to put that to music. Okay. And just so you know, immunoblots, they are 4 different immunoblots. There's Lyme, Borrelia, there's relapsing fever, Borrelia, Bartonella, and Babesia. And they can offer you any 3. It's like a Chinese restaurant, column A, column B. Any 3 that have a certain fixed price. And if you want to add the 4th into it, we'll give a further discount. It's just the commercial part of this whole thing. So this is what I want to summarize. Number 1, a positive culture confirms active disease. The thing was infected, and there the day the blood was drawn. Okay. The highest culture yield I found years ago, and still true today, highest yields is expected during symptom flares, especially if the person's not on treatment at the time of testing. What I found during studies with cultures, even years ago, was that all of the tick-borne diseases have waxing and waning of symptoms. Famously, Lyme is a 4-week cycle. Some relapsing fevers are 2-week cycles. Babesia, Bartonella, maybe every 4 to 7 days, depending on the patient. But if you have your patients keep a diary, they can say, I'm seeing a pattern. So when you're seeing the symptoms flare, that's the best time to do a direct test after culture. Also, what I found out over the years is that if someone's on full course treatment, you're not going to expect to find a positive culture. I mean, it may be possible with this new technology, but with the technology I had back in the day, if they were on antibiotics, it really didn't make sense to do the culture. And we really had to wait for Lyme, which is a slowly growing organism, about 4 weeks from the last treatment until testing. I think Bartonella would be more rapid. Likewise, the Rickettsia, Anaplasma, Ehrlichias. Just not sure about that. This is something you'll all learn through experience. But I also don't want you to stop treatment just for the sake of testing someone. I mean, no, you have to treat a patient if you think they need treatment. If on the other hand, they're done with treatment or they're taking a break or they're having side effects, so let's just stop and regroup, let some time go by, see how you're feeling, and let's retest you next month, then that would be a great thing to do to the culture. Again, highest yield is if you do multiple methods, a direct plus indirect, such as a culture with or without a fish, plus immunoblots. Now, the immunoblots, as you know, are very highly sensitive, they're highly specific, but there are still tests that relate to B cell function. Lyme patients sometimes have B cell deficiencies. In that case, you would substitute the T cell response assay, the IGeneX spot, for the immunoblot. And just a word on T cell assays, I did a lot of them years ago, and I had trouble because T cells, the whole idea of it, when the blood is drawn, the T cells have to be kept alive in transit and into the lab where they actually test how they respond to different stimuli. So if you're sending your blood to a lab that's overseas or a commercial lab that doesn't jump on it right away, you're going to get false negative results because the T cells by that time have petered out. So just if you can do T cell tests, use an American lab, hopefully IGeneX. And finally, the light bulb moment, my aha thing is like, really consider deeply the implications of not doing this kind of combination testing. I mean, it's expensive, I know that. Yes, Medicare covers some of this, and some commercial insurances do cover it. Sometimes it's not. But I think it's more damaging to a patient to not get tested and treated and diagnosed than to worry about a bigger credit card bill. But of course, that's easy for me to say. Anyway, that was what my message is for tonight. I do want to encourage you to look at the IGeneX website. There's so much information on there that a lot of people don't realize. Besides the information about the testing, what the methods are and interpretation and all that, there are copies of webinars that you can watch for free, copies of research papers that are very important, and of course, customer support is always available. So I didn't go overtime for the first time in probably 400 years. So I'm going to stop at this point and allow for Q&A. Hopefully Joe is still on the line. He can direct the Q&A, and Dr. Shah hopefully joined us so she can answer the questions that I cannot. Okay?
Yeah, great. Thanks, Dr. Burrascano. And Dr. Shah, if you're on the line and you want to say any words, you're the leader of IGeneX, of course, and you've been spending years in getting culture ready, and now we have a great product. So do you have any thoughts you want to share?
Well, I can say one thing. Can you hear me?
Yep.
Yes.
Okay. This was a very difficult task. We were trying to only grow Borrelia. We had no idea that we could grow Babesia and the other pathogens quite well in culture, because as you all know, Babesia microti cannot be grown in culture. Even to this day, it has to be grown in a hamster or a nude mice. So we were very, very surprised that in the culture medium that we have developed, Babesia does grow. And in fact, with Babesia, microti, when we saw that, we confirmed it by sequencing, and and the other thing we did was we allowed the culture to grow for 16 weeks. About 100 cultures were grown. And we were able to show in a few of them that where Babesia grew, after 16 weeks by reverse Western blotting, we were able to show that the Babesia were really growing. So, that was real proof to show that Babesia grew in our culture medium. And clinical studies have clearly shown that. So we feel that the culture is extremely important for Babesia, especially because there are species that we know, in fact, humans, which we cannot detect by any other method except on the immunoblot. It will show up as genus level. but the IFAs won't detect it. So the commercial tests out there are not going to be good for species other than Microti and Duncani to be detected, whereas the culture, we will, if there is Babesia present, will detect it. And by sequencing, we should be able to identify what it is. This is not the information will be provided to the patients, we'll only provide the information as Babesia genus, Microti, or Duncani. But the point is, we can detect species that are causing disease in the humans by culture, and this seems to be a very useful technique combined with the immunoblots. Thank you.